Good morning, everyone. A little public service announcement. This is Dr. Garais, week 6. Today is February 9. This class is MED110 5DAX. The first announcement is that, one, I've been informed that the laboratories for and the on-campus meetings are mandatory. So I'll be placing them on your announcements. But right off the bat, since this is recording, it is Tuesday, February 23, Tuesday, March 2, and Tuesday, March 9 are on-campus days for this particular class. The 23rd is week 8, March 2 is week 9, and March 9 is week 10. Week 8 and 9 are reserved for laboratory and lecture, and week 10 is reserved for the written examination. If you cannot make it in, I repeat, if you cannot make it in for whatever reason, safety reasons, work reasons, I need to know as soon as possible so that I can give you alternative assignments or so that I can do something so I can give you credit for attendance, okay? That's very important because the people who automatically show up will automatically get attendance. I'll also be doing the lectures that day via Zoom so I can record it. But again, I have to repeat, for those days, we have to be present on campus, Health Lab 1, 4th floor, Alexandria campus. And it'll be placed in your announcements later this morning. What is due today? Today is week 6. And as a clarification, anything from the week prior is due the next week. So that last week was week 5. So what's due? Your task 5, discussion 5, and lesson 5. And if you have yet to receive your actual copy of your midterm exam, please shoot me an email because again, Gmail and Yahoo goes to our spam sometimes. So try to use your official Stratford email with the correspondence with the university and your other professors. And also, as a little side note, your other professors, they don't have access to your private email. They only have access to your official Stratford account, which is mymail.stratford.edu. Also pay attention to that and your student portal because there are a whole bunch of students calling me like, why can't I register? Because you have a hold. How do I know I have a hold? The emails go out on your official Stratford email, and when you go in your student self-service portal, and how do I get, if you missed your new student orientation and don't know what your portal is, well, on the top right here, where is it? Emails, not faculty, here, student, right? There's how-to guides, and where's the resources? Here, under the resources tab, you click on this self-service portal. That has your grades, it has any alerts from student accounts, and please pay attention to that because right now it's relatively early, but let's not wait until March to register. Register by this weekend, please. It's such a shame that people miss out on their opportunity to register or miss out or don't get the right classes and they're not able to apply to the School of Nursing because of missed out classes and missed opportunities. And just also a little public service announcement as well. We had a couple of more failures for the TEAS exam. Please don't take that TEAS exam lightly. We're not allowing people in because of scores are, the minimum score is like what, 70? People are scoring 67s and 68s. It's so close. So it shows that, you know, the preparation was lacking. And like I always said, you don't want to be a nurse with 70% of the knowledge or 70% capability of reading comprehension. So please don't be one of those people. So again, task 5, discussion 5, lesson 5, due today at 9 a.m. If you can get it to me before 12 noon, I won't have any deductions. And those of you who get it to me a little bit late, see that. But I also have to be, I've been cited. My boss looks at my course shells, and they're telling me that I'm giving you guys way too much leeway, and that's grade padding, and we can't have that. So with all those public service announcements out of the way, please, 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 right, get that email to me if you cannot make those dates for the laboratory and the final exam, so I can make other arrangements for you. So what are we doing today? Week 6, task 6. We are doing, oh, the big one, heart. So the cardiovascular system. Chapter 19 in your textbook. These are some nice videos here, but let's start using our textbook again. You go into OpenStax, table of contents, chapter 19. And it's also chapter 20 as well, because that's also cardiovascular is not only the cardiac, the heart, it's also all the tubing that's involved here as well. So let's look at the function of blood, because that's the thing that the cardiovascular system is transporting. So there are 3 formed elements or cells that are in your blood. You have your red blood cells, also known as erythrocytes, white blood cells, known as leukocytes, and your platelets, known as thrombocytes. You should know that because of medical terminology. And if you haven't taken your medical terminology, well, red blood cells, erythro means red, white, leuco is white blood cells, and platelets or thrombocytes, that is your clotting cells. So essentially, your red blood cells are carriers. They carry things, and the 2 main things that it carries is oxygen and carbon dioxide. We need oxygen as fuel, we already know that, to make ATP, and it also can carry other nutrients such as glucose. The red blood cells are, well, let's talk about function first, and then we're going to start talking about what they look like, which we kind of know what they look like already because of the first week, that histology video, and I'm going to review that picture as well. So the red blood cells, they carry stuff, okay? White blood cells, they are our defense, okay? They are the white knights. They take care of any foreign body or any potential pathogen that could invade our body, which happens on a regular basis. But as long as your white count is good and sufficient, you should be able to defend yourself, and your immune system should be intact. And last but not least, you have little wounds and little cuts all along your body during, hold up, wait a minute, I gotta hold. Mom, what?
His glass, his
All of that is in the bag on top of the piano. Okay, sorry. Red blood cells, white blood cells, and white blood cells are defense. And lastly, platelets. All across your body, you have little tiny cuts and little tiny spaces where the blood leaks out. When the blood leaks out, it has to be plugged up, and that's where these platelets come into play. So you have these little blood clots. And again, like everything in this world in physiology, there has to be an optimal number. So too little of these things cause problems. Too much of these things cause problems. Too much red blood cells, not good. Too many white blood cells, that means you have an infection. Too many platelets, you have thrombocytosis, and you're going to start clotting all over the place. And then that's when you get heart attacks and strokes. Okay? So that is the formed elements, or the cellular portion of your blood, or the dry portions of your blood. Now, the wet portions, of course, is the fluid or the liquid, and that's plasma. Now, inside the plasma are a whole bunch of proteins, and ones that are in particular is your immunogens, right? Your immune proteins. And we do plasma assays or plasma tests to see how your immune system is, to see if those proteins are in your plasma. Or if you have any antibodies towards any diseases, they would be picked up in your plasma. Okay, so formed elements, plasma. Dry parts, wet parts. Formed elements, cellular parts. Okay, now you know, and their functions. Now, if you look at this, you could see if you have anemia, this is normal. And the ratio between the formed elements and your plasma is called your hematocrit. Okay, so typically it's around 44% or whatever. It depends if you're male, female, young, old. But the hematocrit tells us things. So if the formed elements are down, that means you have some sort of anemia. So you're going to have a decreased hematocrit. And if you have too much, or even if you're dehydrated, if you have too many cells or not enough fluid, you'll have an elevated hematocrit. So this is a nice little clinical thing. And hematocrit is usually part and parcel of your CBC, also known as your complete blood count. Okay, here are also some other plasma proteins. I already talked about the immunoglobulins. I already talked about antibodies. There's also albumin. And albumin is the most abundant or the most important plasma protein. And its function is to, it's also a transport vehicle, but what's big about albumin is that it draws water from tissues. So albumin is big on water transport, and it's directly related to dehydration or the hydration status of my patient. So you have albumin, you have your immune globulins, antibodies. You also have fibrinogen. Now remember, if you have the ogen or a suffix on something, that means it's a precursor to something. So fibrinogen is a plasma protein that is required for clotting. So if you don't have enough fibrinogen, or you don't have enough platelets right here, either way, you're gonna bleed out. And that's not a good thing. Remember, your blood can't be thick, nor can it be thin. It has to be just right. And if there's not enough fibrinogen, your blood will thin out. And then what will happen? You'll bleed out. Because all the little nicks and cuts, it won't be able to hold the blood in, and that's not a good thing. And you could see here, plasma is anywhere from 46 to 63%, depending on your hydration status or your cellular component status. Just know it's around a little under half. Alrighty. So that's blood. Now, where does blood come from? Well, they come from these stuff called pluripotent stem cells. Now, pluripotent stem cell, you got tons of them when you're a fetus. That's why fetuses are really, really popular in the world of stem cell research, because stem cells can be anything. And then as long as the DNA dictates it, it'll tell it to be a hematopoietic stem cell. Then the hematopoietic stem cell, also known as hemocytoblast, hemo means blood, cyto means cell, blast means immature cell. So because once we have these stem cells, it creates blood cells. And we've seen this before when we talked about the different types of white blood cells. So just know that pluripotent or multipotent stem cells then can change depending on what's inside their nucleus here on their DNA to what to do. Now, the most important blast cell regarding red blood cells is your retics, also known as retic is a slang term for your reticulocyte. So if my patient's bleeding out and they need to have a whole bunch of new red blood cells, you're going to see an increase of reticulocyte count if someone has a bleeding diathesis, if they're bleeding out, or if there's hemolysis going on. There are drugs that break down the red blood cell. And if we look at this red blood cell, you see it's like a lifesaver, and there's no nucleus in it. So it's the term for its morphology is called biconcave disk. And it makes sense. A lifesaver, what do you do when you like an inner tube. If any of you ever went tubing down a river or something like that, there's a hole in the middle, and it makes sense. In that hole, there's no nucleus, but there's hemoglobin. And hemoglobin, hemo, blood, globin, protein, is a protein that holds things in there. And if you even look at the hemoglobin structure, let's look at this picture of it. If you look at it in 3D, you can use your imagination. Doesn't this look like one big inner tube with a hole in the middle? And then it has a seat here, and then it has a seat here, a seat here, and a seat here. And there's this heme group, right? And that's iron. So if you look at this red blood cell, right? It's like an inner tube. It's like a lifesaver. Things sit there in the middle, and you have hemoglobin that has these different chains, and the heme group, which is iron, and that's why iron is really important in your diet, right? You could see how it sits things, and the major things that it sits is oxygen and carbon dioxide. So red blood cells bring oxygen in, carbon dioxide, and here someone has this analogy, which is really neat, that it's cars. It holds things. It has seats. Now, another really cool thing about this seat is, for example, you have a specific type of hemoglobin, A1C, also known as your glycosylated hemoglobin. It also sits sugar. So inside, we know for 90 days your glucose status. So you can't lie to your physician that, oh, I've been really good on my diet when you've just been fasting for a couple of days so you can look good when it comes time to go to your appointment. I do that all the time. I just had an appointment for 3 days right before my appointment. I was really, really good. Everything was good. The cholesterol went down. Everything went down. You know what didn't go down? The glycosylated hemoglobin, or hemoglobin A1C. That didn't go down because in reality, the last 90 days, I still eat Doritos. I had a couple of beers. It's so noticeable. So I just owned up and said, yeah, I'm not good. I wasn't good. I even lost a couple of pounds, but the A1C is still bad. And that is also a good indicator, especially for a pre-diabetic like me, if they're following their diet, if they're taking their meds. And now, because my A1C is bad, guess who has to be on meds now? Yours truly. Now, platelets. If you look at platelets, you see it's not really a cell. It's little bits and pieces. And these bits and pieces get sticky. And along with fibrinogen, they get very sticky and they form a web. And that's what a blood clot is. And that's what keeps your blood inside despite all the little nicks and cuts in all of your blood vessels. We already know all the white blood cells, right? You got the memory cells. Remember here from your T cells. Remember HIV? Remember from your midterm? Just because you learned it doesn't mean you have to go back. Remember your thugs, like your NK cells, right? We already know about erythropoietin. It is a hormone, right, that signals your bones to go make more blood cells. Thrombopoietin, of course, same thing. Erythropoietin deals with red blood cells. Thrombopoietin, of course, deals with platelets, right? Cytokines, of course, we already talked about that. Though cytokines and interleukins, those are really big things that we're looking for in the patient's plasma to see how the immune status is of our patient. That, along with, I also look at the differential white blood count. Now, the differential white blood count, your CBC or complete blood count just has a total number of white blood cells. That gives me a rough estimate, but maybe you've heard the word CBC with diff. That's slang for complete blood count with differential. And the differential is the one that gives me this thing, all the percentages of the different kinds. And based on these different percentages, I can tell what kind of anemia you have, if you have anemia at all. That's also another thing. My wife's infamous for that. She's always talking about how she has anemia. She always feels tired and pale. But then when we take her blood, it's perfectly normal. So does my wife have anemia? No. The only time you have anemia is when there is a blood test that confirms it. She has anemic symptoms, so we have to go investigate further why she's tired, why she experiencing some pallor, and all these other things. Here is a nice chart that has all the functions, and we already talked about this in the previous chapters, and you'll be responsible for it again. Okay. Here's another picture, wonderful, of the biconcave disc, red blood cell. Here's the hemoglobin that we talked about, right? You could see the heme groups, right, which has iron associated with it. Let me make this a little big. Fe2 plus, right? And remember, so that has a 2+ charge, and that's going to attract certain things. Now, when something sits on these things, it changes the chemical structure. So if oxygen sits on it, it now forms oxyhemoglobin. If carbon dioxide sits on it, it's carbinohemoglobin, right? Now, when there's more carbon dioxide than oxygen, that's when your blood gets more maroon colored, right? And then when there's way more oxygen, that's when your blood gets like bright red. Erythrocytes, typically 120 days, more or less. And if you recall, remember, it's the spleen that kind of filters all the old red blood cells out. More specifics, disorders. This is not a pathology class. Leukocytes. See, all over your body, you got little infections. And of course, you see here, the big thug, the macrophage, and then you have other things like the eosinophils here that releases chemicals to do what? Attract that macrophage, and the macrophage will eat up all this bacteria right here. Let's get out of blood. Let's get to the heart. Now, this is for future training. This is the clotting factor cascade. It is complex, and you really should know your biochemistry when you start talking about this stuff. It's just a lot of memorization. Just know that there are a whole bunch of clotting factors. Here's one, prothrombin, fibrinogen we already talked about, right? Thromboplastin, and maybe you heard the term in laboratory science, PT-PTT, INR, which is prothrombin time, thromboblastin time, or partial thromboblastin time, international normalized ratio. Now, that means it's the time that it takes your these clotting factors to work. And if that time is prolonged, you're going to have a bleeding diathesis, and therefore your patient's going to start bleeding out. And then if there's too many, right, you're going to have blood clots, and that's not good. So if you have a whole bunch of blood clots, we give you stuff like heparin and tissue plasminogen factor. What's the other one? Warfarin, Coumadin. We give you blood thinners. And those are really good for cardiovascular patients, especially if they're diabetic and cardiovascular patients, because you got to think about it. Which is easier to pump, water or molasses? Molasses is like essentially water with a whole ton of sugar in it. And isn't that the blood picture of a typical diabetic, such as myself? ABO blood group, we'll talk about that another time. Just know that on the red blood cell, there is, we all know on the not biconcave disk, on all red blood cells, there's glycoprotein coat. Like on all cells, there's a coat, glycoprotein coat, that identifies what it is. And the red blood cells have a specific, and they have two systems, your ABO system and your RH system. So for example, if I'm B positive, the B deals with the ABO system. The positive or negative deals with the RH system. B positive doesn't mean you're positive for B. So when you're looking at a blood type, when they say A positive, AB positive, the letters are part of the ABO group typing, and the RH is part of rhesus monkey or the rhesus typing, which is so you're either positive or negative for RH, and then you're either A, B, AB or O for the ABO blood typing group. And this is how we can tell. We can have antibodies. We run a sample. So you see there's clotting here in the anti-A chamber. So that means this patient is A, right? And there's clotting in the anti-D or anti-RH chamber. So this particular patient is A positive. And you can see there's no clotting here. Okay, and you could see, look at this, all these little glycoprotein coats. So if you're A, you have what? This set of glycoprotein coats. So it'll interact with antibody B. If you're B, it'll react with, and it goes antibody A. If you're AB, it shouldn't react to anything. And if you're O, if you're AB, it goes, you don't have any reactions. And if you're O, you can have reactions with anything. I mean, let me take that back. I said that the wrong way. How's this? There's this patient here, that's A positive, right? So you can't give it to a B person because a B person has antibodies against A. This B, you can't give it to an A person because it has antibodies on A will attack these Bs. AB, right, is the universal recipient. You can give that to anybody with A or B because they'll have minimal effects because they share the glycoprotein coat. Now the O is the universal donor. You can give that to anybody because you could see there's nothing on their coat that would react with them. So O, universal donor, AB, universal recipient. You can't give A to anybody who's B, and you can't give B to anybody who's A. All right. So if you didn't get that, oh, here, they have it here. Okay. Didn't get that, rewind and look at this chart. Okay. So what kind of questions could I ask you on an exam? A patient who is type A blood has A antigen. Patient with type B blood has B antigen or B glycoproteins all around it. A patient with AB has both A and B antigens. A patient with type O blood has no glycoprotein A or B. Therefore, right, an A can give to another A and give to an O. A B can give to a B and to an O, right? AB is the universal recipient. It can take anything. O is the universal donor because it could give to anyone. The military is now currently, the United States Army in specific, they're about halfway through having the capability of removing all, like let's say you have AB blood, they now have the capability or becoming to have the capability of removing all these glycoprotein coats so that everyone can be type O. How neat is that? Back in the day, when I was in my lovely corps, we put all the guys who had type O blood in, we never put them in the front. We always put them in the back just in case anything bad happened in the front. There's no such thing as best group. It's just, those are the, like, that's a weird way to categorize best. So I don't know what, O people are dirtbags and A people are the best. No, it's just, it's all the same blood. It's just that the compatibility issues. But if you want to be a donor, O is the best. If you want to be a recipient, AB is the best. Oh, let's get out of blood. I want to talk about the main thing, which is heart. Let's talk about the heart. That's why we're here. Oh, look at these lovely questions. I should just take these questions and copy and paste them, shouldn't I? Hint, hint. Okay, the heart. Okay. Let's look at this. Where's the heart located? It's about the size of your fist. It's located a little bit more on your left side of your mediastinum, which is your thoracic chest cavity. It is made out of 4 chambers, and we're going to see in a moment. And anytime you see blue, that is a deoxygenated blood vessel, most likely a vein. Anytime you see red, it is an oxygenated blood vessel, meaning that the red blood cells mostly have oxygen or oxyhemoglobin, and that is most likely an artery. Here's your largest diameter artery in your body, and that's your aortic arch. And what else is important about this picture? Nothing yet. Let's look at this craziness right here. Now, when you look at this, I'm going to have a separate video that I want you guys to see, and that's called the box diagram. But right now, I'm just going to go over what you're responsible for. All of this. You should be able to tell me what's what. Now, the first thing you got to do is, I first have to realize that anything in blue is deoxygenated and everything in red is oxygenated. And can you see that it could be like, if you simplify it, there's this room up here and a room up here. That's got to be your atrium. And remember, you're looking at your patient. So this is the left side, the red side, or oxygenated side, or systemic side. And here's the blue side, the deoxygenated side, also known as the pulmonary circulation. Okay? So how can you identify what's what? Okay? So an artery typically brings blood away from the heart, as you can see here. The blood is going away, and typically arteries are oxygenated. And you should know the difference between arteries and veins because we already went through that before. And arteries are typically, they're thicker walled, and that's where we get our blood pressure. So it's under higher pressure than the veins. Now the veins are coming back to the heart, so they should be coming back low pressure. Now the veins, colored blue, right? Because most of the blood is deoxygenated, and the veins have valves, and the valves prevent backflow. And if you notice, blood only goes one way, hence the term cardiovascular cycle or cardiac cycle. So to identify it, first you have to realize, wait a minute, where's my right, where's my left? I now know that if I'm looking at an open heart like this in a textbook, it's what? This is the left side, this is the right side. The left side is typically of the heart is oxygenated. As you can see, it's all red, and the left side is deoxygenated. The right side, also known as the systemic circulation, and the left side, also known as your pulmonary circulation. So if you see here, this is the right side, and it's a relatively small room called your atrium. So that's got to be your left atrium. This is a larger room, and that's called a ventricle, and that's your left ventricle. So if that's your left atrium, this is your left ventricle, this has to be your right atrium, and this has to be your right ventricle. And I'm preempting my other video. In the box diagram video, I simplify, well, not me, my mentor in internal medicine, well, one of my mentors for cardiovascular was a Dr. Kagiwa, and he was a former professor for the lovely Boston General and Harvard Medical School. Well, it's better to look at this diagrammatically, but for the purposes of this lecture, I'm just going to show you right off the bat how you can just identify it. Now, you see these? These are valves. Do you see how these two valves here and this valve here are in between your atrium and ventricle? So that has to be an AV valve or an atrioventricular valve. That makes sense. Atrium, ventricle. The valve that goes in between is an AV valve. The valve on the left is called your mitral valve, also known as your bicuspid. The valve on the right is called your tricuspid because cusp means leaflet. The one on the left has 2 and the one on the right has 3. You can also look at these valves as well. Here's your pulmonary semilunar valve because this goes to your pulmonary artery, which goes to your lungs, hence the term pulmonary. Here is your aortic semilunar valve, and that makes sense because it's now emptying into your largest artery, your aortic arch, which is right here, and that goes all out into the systemic, right? In your right atrium, you have a vein coming from the top of your head. That's your superior vena cava. And look at your medical terminology powers. Your SVC, or your superior vena cava. Superior means what? Coming from up top. Vein, cava. Cava means cave. It's big. So your SVC, or your superior vena cava, has to be deoxygenated blood coming from your head going down into your right atrium. And now from the rest of your body, you have your, if you have a superior vena cava, you gotta have an inferior vena cava, okay? Here's your pulmonary arteries. You have one set here, another set here that goes behind, and they empty into your left atrium. Now, one thing you could do is you could look online for a diagram similar to this, or you could take this, put it in Microsoft Paint, erase all of this, and do A, B, C, D, E, F, G. Just imagine if you did that 10 minutes a day, and then how easy would this question be, identification question would be on your midterm. Hint, hint, this is going to be on your midterm. So start looking at it now, start memorizing it now. Hint, hint, you're going to see this in pathology. Hint, hint, you're going to see this again in pharmacology. Hint, hint, you're going to see it again in your clinicals. Hint, hint, you're going to see it again. You guys get the drift, right? Okay. So, oh, by the way, you look at your midterm, oh, this particular class did okay, a little bit lower than overall class average. But if you see, some of you still retained your grades, meaning if you keep on doing all your discussions, all your other stuff, if you tank your exams, you still can do pretty well. I have people who failed, outright failed their midterm, but still got an A- B+ because they did all the discussions, they did all their tasks, and they did all their lessons. So 110% exam isn't going to kill your grade, okay? But if you didn't do all that stuff and you tanked the exam, well, actually, for some people, it brought them into the lovely, lovely world of failing a class. And please don't. It's just too expensive to fail. Here are the layers of the heart. And the key to knowing any of the layers to anything is knowing your medical terminology powers. So if you look at pericardium, structure of, peri, surrounding, cardi, the heart. So the fibrous pericardium has to be the thing on the outside. And then you have your parietal layer and your visceral layer. Now, parietal has to be the one on the outside. The visceral has to be the one on the inside. Now, in between, it goes those two layers, it goes is a potential space where there's some fluid. And the function of this fluid is to decrease the friction of this heart pumping. Because imagine all day, every day, since maybe 5 weeks age of gestation, your heart has been beating until the day and moment you die, right? Now you can also imagine pathologies. Let's say I bang up my heart and I get blood or pus in here. You could see how that can squeeze on your heart, and that pathology is called pericardial tamponade, and that's no bueno. You have now also your epicardium, which is epi, right? Just like epithelial layer, right? Then your myocardium, which is the majority of your muscle layer, because the heart, that's what it is. It is a muscle. All it does is contract and pump. And then, of course, your thin, delicate layer of your endocardium. So if you have an endocardial pathology, how much trouble are you in? If you have a deep myocardial pathology, how much trouble you're in? So you can see how whoever you believe created us, right? They have multiple layers so that any pathology would have a hard time, or any damage to my chest will have a hard time. And look, you have this huge bone, set of bones and muscle blocking your chest. So it protects it. Oh, looky here. These are the external features of the heart. First, again, back to, do you think I could take this, erase all of this, and just put A, B, C, D, E, F, G? You betcha. So what should you do? You should do that and start looking for that. So look how easy it is to make a quiz. Cardiac anatomy quiz. Look up images. Oh, how do you do? Do you think you could sit here and practice this? 10 minutes every morning. What would happen? What would happen after a week? You'd know it. Use your Google powers, all right? So how do you look at this? How do you know what's front and what's back? Do you notice here this anterior interventricular sulcus, which is sulcus means depression or groove or ridge. And when we're in anatomy in our lab, we'll be cutting this bad boy up and we'll see there's a ridge in here, right? And of course, red is arterial and blue is venous. So all these arteries here on the outside of the heart, those are your coronary arteries. They actually feed your heart, right? So you have your left coronary artery because remember, I'm looking at this anterior, this is the left side, this is the right. This is my left ventricle, this is my right ventricle. This is my right atrium, this is my left atrium. Here are my pulmonary veins. Here's my inferior vena cava, superior vena cava, aortic arch, right? And my pulmonary artery. Now, remember the kind of thing that I said that if it's moving away from the heart, it's typically oxygenated. If it's an artery moving away from the heart, it's typically oxygenated. Well, the pulmonary system is backwards. So the pulmonary artery is deoxygenated blood going away from the heart. The pulmonary vein is coming from your lungs, and that's oxygenated blood going into your left atrium right here. So be able to know what's the difference. Because one of the questions that I once asked is, I moved all of this, I showed this, and I asked you, what view is it, front or back? Anterior view or posterior? And I know it's anterior because look, my atria are up front. And looky here, my great cardiac vein and my anterior interventricular artery, also known as your left anterior descending artery, right here, which is, by the way, is going on diagonally towards my apex. Now, if you see their atria are not in the are hidden, mostly hidden, and you see this middle cardiac vein running straight towards your apex, that's how you know you're in the back. You also have here your cardiac or your coronary sinus. That's a huge vein, and that's in the back. So if you see this great cardiac vein here in your posterior interventricular sulcus, so now this is the back. Don't be fooled. Now, if I'm looking at the back, this is now my right ventricle, and this is now my left ventricle because I turned everything backwards. And if this is my left ventricle, this has to be my left atrium, okay? So be able to distinguish front from back, and this is the typical diagrams or pictures that I could show you. You're responsible for any and all of these. So you could see how you got some work in front of you, okay? Now let's look at the internal structures of the heart. And again, it's the anterior view. How do I know it's the anterior view? Look, I'm looking at the atrium. They're right in the front. If I use your imagination, I cut all that. So again, I'm going to try to identify things. I know this is anterior view. This is the left atrium. This is the left ventricle. This is the right atrium, right ventricle. So we're now going to focus on the interior structures here. So remember we talked about the valves? This is your mitral valve, also known as your bicuspid. See, there's these two little fingers here? Those are your papillary muscles. They're connected to these cords here, which are your chordae tendineae, and connected to the leaflet of this mitral valve, also known as your bicuspid. This one, you can see here, 1, 2, 3, right? 3 papillary muscles, the 3 sets of chordae tendineae, to this, your tricuspid valve. Both the mitral valve and the tricuspid valve are AV valves, atrial ventricular or atrioventricular valves, atrioventricular valve. And if it's on the left side, it's mitral, also known as your bicuspid valve. Doesn't that look like a beautiful both A and B question? Hint, hint. And if it's on the right side, that's your tricuspid. Now, the other set of valves going out of your heart, if it's coming out of the left ventricle going into the aorta, that has to be the aortic semilunar valve. And if it's on the right side going to your lungs, that has to be the pulmonary semilunar valve. Okay. Let me just deal with this spam, of course. All right. So another thing you're going to notice, you look at the atrium, they're smooth because remember, things going into the atrium are low pressure, right? They're veins coming back into the atrium, and veins are typically low pressure. But when I have to push against, on the right side against the lungs and on the left side against the systemic circulation, you can see how it's rough all in here and it's thicker. Look how thick this wall is. It's myometrium. Look how thin the atrium is. So that makes sense. The ventricles are under high pressure, and this is called trabeculae carnae. This term right here. All these little branches, and they're very pronounced when we do our dissection. And that's in week 8, week 9 of this particular term. We cut up a whole pig, and we also cut up a heart. And why do we call them semilunar valves? You can see how it's like, it's really hard to tell here, but it looks like a crescent moon, right? When you're looking at semilunar valves, you got to use your imagination a little bit. But if you look at it sideways, see, it's like a crescent. Okay. And that's your semilunar valve. Okay, what happened? Something's messing with me. Okay. And we already talked about the coronary arteries and how do you get heart attacks? Well, your anterior interventricular artery, also known as your left anterior descending, most common artery to be blocked. This is no exaggeration. Your coronary arteries are very thin. Just imagine you got a blood clot here, and it'll prevent now blood from going in this area, which is your left ventricle, and then you'll have a blockage, and that's called a myocardial infarction, also known as a heart attack. And heart attacks are blockages of these coronary arteries. It's really easy to do. See, look at that. Right? Oh, this is bad. Look at that. Wait, well, maybe I see it on mine, but do you see it on yours? See that? It doesn't take much. And that's the process of a whole bunch of beer and a whole bunch of Doritos. Yes, I'm talking about myself. Okay, what's so special about heart muscle or the heart muscle cells? Well, they beat on their own, and they beat by, and the cool thing is when they're connected together, it forms a syncytium, and then they beat together. Hence the conduction system of the heart. I don't like this picture. Let's get a better picture. You can see I lectured this recently and it's typically colored yellow because nerves are full of fat. But in this case, they colored it green. Let me find it. Well, this one they colored it red, but hey, it's sometimes colored yellow. So your heart is essentially a muscle. A muscle requires a brain, a wire, which is your cranial nerve 10, also known as your vagus nerve. It's written like a Roman numeral X, right? And it connects into this SA node, which is a bundle of nerves called your sinoatrial node. Your sinoatrial node is known as the pacemaker of a heart, located, and it starts here in your right atrium. Then the signal, also known as an action potential, which is a little tiny little bit of electricity, then travels to your AV node. Your AV node is like the brakes. Brakes as in B-R-A-K-E-S, you know, like the brakes on your car. It slows down the signal of your sinoatrial node. Your sinoatrial node typically fires around 100 beats per minute, but your AV node will slow it down considerably because you need time for this atria to fill up with blood, and then you need time for the blood to then go down here to the ventricles. So the next stop is from SA node to AV node. It goes here into your atrioventricular bundle of His. Then it goes into your left and right bundle branches, and then ends up here all along the external walls of your both ventricles into what is known as your Purkinje fibers. So it goes like this, in this order: sinoatrial node, pacemaker, then AV node, then bundle of His, then left and right bundle branches, and then your Purkinje fibers. Now, if there's any problem with the electricity here, we're going to pick it up on an electrocardiogram. Okay. So pacemaker, AV node, the brakes, and that is the conduction system of the heart. Know the order, know the location, because do you think I could easily take this picture or take whatever random picture and then do what? A, B, C, D, E, F, G? Yep, I could. I will. I won't do it like this, though. That's stupid. I have to do it in context of what the heart looks like. I do it like this. And do you think you could take this picture, erase all this, and then 1 or 2 minutes in the morning, right before you get in your car, go to work? Or you hop on to your computer to go to work? This is EKG stuff. You don't need to know this yet. Pressures, blood flow, no. Oh, yeah. Now, what are the phases of this cardiac cycle? And what's the cardiac cycle? It's the trace of a single drop of blood from your left atrium all the way through the whole body and back to the left atrium. And you have systole and diastole. Now, systole is when the heart is pumping at its top. So that's when you look at blood pressure, like let's say it's 120/80. The systole is the 120, is the big number, or 120 millimeters of mercury. Millimeters of mercury is the metric or measurement of pressure. So that's your systolic blood pressure. And your diastolic blood pressure is the pressure when your heart is resetting or filling up with blood. So if your patient has 120/80 blood pressure, the 80 millimeters of mercury, or the bottom number, is the diastole, okay? And blood pressure is really important to us because if it's too little, the blood won't be able to pump to where it needs to go, and then you'll go into shock. Shock is the cardiovascular system's inability to pump blood to its periphery to where it needs to go. Now, if it's too much, you'll have hypertension. And we all know the effects of hypertension. It causes damage to a lot of the other organs, especially your lungs, your kidney, right? Your liver. It's never a good thing. And it goes back to what we always talked about since our first lecture. The function of the body is homeostasis. It wants to be in the middle, okay? Also, a little side note regarding your heart. You can't really control it. We already know that from the autonomic nervous system. So if you're scared, you're going to have increased heart rate, increased blood pressure, because remember, I need that epinephrine, I need that sugar in my system, so I know either to run or to fight. And hence the term fight or flight, sympathetic autonomic nervous system. So if you're looking at, don't worry about this. If you're looking at heart sounds, ooh, geez, this brings back memories. Those of you, if you're ever going to medical school, please call me first so I can either, one, talk you out of it, two, go over high value topics for your MCAT, also known as your Medical College Aptitude Test. This is a big topic, and it deals with the blood pressures, right? But I want you to look at this part, the heart sounds. Lub dub. When you typically listen to a healthy heart, you'll only hear two sounds, right? Because you'll hear S1, S2. S1 is the lub and S2 is the dub. Now, it goes, what are heart sounds? What makes a heart sound? It is the opening and closing of your valves. So if you could see here, when your valves close, it makes a sound, right? It's lub and dub, and it matches up with here with your atrial and your ventricular pressures, okay? And you can see if it's at its maximum, 120 millimeters of mercury, which is up here, and its minimum, it's 80. So this person's blood pressure is 120 over 80, right? Now, what's a murmur? Is an unusual sound. Just like, you know, your old door in your home, it makes a specific sound. So if the door is a little damaged or there's something on there or the pressures aren't right, it's going to make an extra sound. And an extra sound is called a murmur, okay? You see this little extra little notchy sound, your S3? That happens when you become a boomer. When you get old enough, 50s and 60s, this becomes normal, this extra sound. Thank goodness I don't have that yet. That's why I torture myself on the treadmill almost daily. Let's look at this because this comes out for you future nurses regarding NCLEX. NCLEX talks, you're going to have to do a little bit of math. So if you're not good at math, get good at math because you'll see it on your NCLEX and MCAT and all future examinations. Can't run away from math. And for you future nurses, if you're not good at math, how in heaven's name are you going to deliver meds? So if you're not good at math, get good at math, find a tutor, get good at math, get good at math. Did I say that? Get good at math. So what's heart rate? We already know what affects heart rate. Hormones, fitness level, age, autonomic nervous system, right? This is obvious, right? So your heart rate is part of this equation called your cardiac output. Cardiac output is the amount of blood that's exiting your heart per minute. And it's dependent upon your heart rate and your stroke volume. Now, what's your stroke volume, right? It's the amount of volume of blood that is happening every time your heart beats. And again, it all depends on certain things. But just know that your cardiac output is relying on your heart rate and your stroke volume. So for example, right? Let's talk about my patient, Johnny. He pissed me off. I put 2 in his chest, right? I shot him. What now happened? The volume of blood will be what? Decreased. So if the volume of blood decreased, if Johnny's body wants to stay alive, what's going to happen to his heart rate? It's going to do what? Increase, right? Let's say, how's this? Let's say my patient has edema and congestive heart failure. There's way too much volume. So this number gets to increase. What number has to decrease? The heart rate. And that's a classic sign of symptom of congestive heart failure, right? If you have back pressure of your lungs and it starts giving you pulmonary edema and cardiac and fluid problems, it's also going to manifest itself in heart rate, and it's also going to manifest itself in overall decrease of cardiac output. And again, if the cardiac output drops to a certain level, too low, that my patient could go into shock. And that's why most patients who go into shock are usually tachycardic. I mentioned the vagus nerve, cranial nerve 10. You see that? It innervates where? Directly right into your SA and AV nodes. And you can see here, you also have an extra set of nerves that are part of your sympathetic nervous system. And you can see, this is the conscious part of your brain up here. Here's your brainstem. You can't control this. That's why you do cocaine. It hits this part, right? The happy zone, right? What's going to happen? Your heart rate will go up. Your blood pressure will go up. Forgive me if I keep on telling the story of my favorite drug addict, Senor Franklin. Mr. Franklin used to always come to my ER, and he always used to pretend that he was this like preppy guy, and he always used to dress impeccably. And every time I'd be like, Franklin, what are you doing back? What are you doing in my ER? What's going on? And he would say, nothing. I don't understand why the police brought me here. He was 23-year-old male. Heart rate was 210, and blood pressure was like 200 over 110. And he'd be sitting calm as a cucumber, but he'd be sweating bullets in the middle of February. So that's activation of your sympathetic nervous system, and it's obvious he was doing meth or cocaine, but he liked cocaine, so 9 times out of 10 it was cocaine or crack cocaine. I feel for those patients. It's really, really rough. Baroreceptor, cardiac, and remember, it's going to mess with your stroke volume, it's going to mess with your heart rate, and eventually adjust your cardiac output, and baroreceptor reflex is baropressure, and it's based on what? Blood pressure. That's why if I squeeze a certain part of your neck, you know, sleeper hold, or also in MMA known as a rear naked choke, you will go out like a light. Not necessarily because I'm choking you, it's part of it, but I'm squeezing on that baroreceptor. I'm telling your body that your blood pressure is way too high. So what will your blood pressure do? It'll bottom out because your body thinks your blood pressure is way too high because I'm pressing on that baroreceptor. Here's some other things that will increase it. You know, thyroid hormone, we already know. Epinephrine, norepinephrine. That's why when you take amphetamine or cocaine-related derivative drugs, it's gonna increase epinephrine, norepinephrine. Calcium also is a good contractility drug. Those of us who are ex-smokers, ex-drinkers know, right? When I was younger, I had to have my cigarette when I wake up. There was no way I was getting up unless I had either coffee, well, both. In my youth, caffeine and nicotine were both my morning pills. No more, because don't want trouble, don't want that heart attack. So let's look at, did we look at everything we needed to look at? Let's look at our list. It's already 10 o'clock. Did we all go over the circulatory system? Yes. We know arteries and veins. Here is a nice blood vessels. You look at these notes, stuff that I went over regarding hematocrit, plasma. These are nice quick notes here regarding the formed elements and plasma. I think it also has arteries versus veins in there. So right here in the step 3, this is nice. Circulatory system, yes. Function and structure of the heart, yes. Arteries, veins, capillaries. Nope, we didn't go over capillaries. And cardiovascular physiology. How does this all work? It's the brain innervation as well. So let's go over arteries, veins, and capillaries. Then we could call it a day. Let's ask the almighty Google to give us something really neat like this. This is nice. Now, remember, if it's colored blue, think deoxygenated. If it's colored red, think oxygenated. And what does that mean? Deoxygenated, that means the red blood cell is carrying mostly carbon dioxide. Red means the red blood cell is carrying mostly oxygen. And remember, you will see definitely in a couple of weeks, if you come to the lab, that it's not really red or blue. They actually all look the same. It's like 18 shades of brown and gray inside your body. But how can we tell an artery from a vein apart? Well, if you look at an artery, you see it has a thick muscular wall in here, and that's your tunica media. It's thick because arteries are under high pressure, and arteries typically are taking blood away from the heart. Now, vein is typically taking blood back towards the heart. Blood only goes one way because they have valves here to prevent backflow. And if you look here, they have a thin tunica media. Now, what's a capillary? A capillary is the bridge in between arteries and veins. This is a very small vein. Small veins are venules. This is a very small artery called an arteriole. And this is where gas exchange occurs, right? So let's say there's blood coming down to my brain. I get rid of the oxygen, and what do I pick up? The leftover carbon dioxide or the waste products from my brain. And where do I pick it up? I pick it up in the capillaries, where there is a mixture of oxygen and carbon dioxide. And you can see it's very thin. It is a single thin wall. If you look at this, oh, what's going on here? Artery, thick tunica media. Vein, very thin. The artery will be this patent open tube, and the vein will be crenated and kind of flat. And if you look at the capillary, it's very small, single layer, and it makes sense because gas exchange has to go in and out through here, so it can't be a thick thing like these two bigger things up here. So know the difference between artery, vein. Oh, here, look at this lovely chart. High versus low pressure, narrow versus wide, thick versus thin, tunica media, right, is the thick one in the artery. Muscle fibers and elastic fibers, that's why we control our blood pressure. This is high pressure, veins are low pressure, right? And veins, V for veins, V has valves to prevent backflow. And if your valves break for whatever reason, that's when you get varicose veins, another V word. Veins, varicose veins, all here, okay? Here's a lovely chart. I could make wonderful multiple choice questions out of this. And again, use your Google powers, use your medical terminology powers, use whatever powers is necessary to do what needs to be done. So we have here, did we go over all this? Arteries, veins versus capillaries? Yes, we did. Let's go over what to do. Of course, next week, what to do? Your concept map. We are in task 6. Now, what does also do next week? Discussion 6, right? Oh, someone's on the ball. Thank you, Ms. Archer, for being early. Innovative ideas and medical technology will enhance people's lives. Try to keep it within the realm of cardiovascular. And do so, if it's technology, it's got to be from late 2020, please. Someone tried to quote something from 1969 the other day in my other class. Or was it this class? You know who you are. I made the comment. Man, it's older than me. That's creepy. And of course, lesson 6. Okay. Go in here, hot tub mystery. Let's look at the case. You download the case. Read the case. Questions 1 through 5 in this section 1. Questions 2, 1 through 6. And keep it simple. Some of you guys write all these long things. And a lot of it's commonsensical. And you know what? Just make it 1 and 2. Questions of part 1 and part 2. That's it. I'm being yet lenient once again because you guys have a lot of stuff to do. Okay? So let us go back and let me stop.